has made an amazing website for you guys. And I want you to also know to look at the website for all of those guidelines that we've talked about. I have links to them. Review them when you're looking, taking care of your patients with POTS. Okay, so let's start.
Okay, let's play Jeopardy. I'm just going to call out random numbers and then we can just go from there. I'll pick the categories. We'll start with the to bleed or not to bleed 100.
Don't pick the number, don't tell them the number.
Okay.
Until we've done the question. Everyone talks and then you choose the number.
Okay. Okay, yeah. Okay, this disease has a prolonged ABTT and a congenital deficiency in factor 8.
Talk with your partner, we'll call in a number. You guys can score your partner so you can find it.
Okay, number 8. Yes, that is correct. Hemophilia A. So hemophilia A is actually factor 8 deficiency and B is 9 deficiency. So whenever somebody comes in with prolonged APTT or impaired tests, we usually do mixing studies to differentiate between either a factor inhibitor or a factor deficiency. So after the mixing study is done, those with normal PT, APTT, and platelet count who have a clinical history compatible with hemophilia or a known family history of hemophilia should have factor activity levels measured. Usually we can use desmopressin in hemophilia A to induce the release of factor 8 from the endothelial cells. But more significant bleeding patients, we have to give isolate the factor concentrates. Okay, question for 200. Most likely cause in patients with mucocutaneous bleeding such as epistaxis, bleeding gums, or menorrhagia. So discuss among yourselves. Okay, number 18.
Are you looking for like thrombocytopenia? Are you looking for a specific disease?
Or specific disease.
Von Willebrand?
Yes, that is correct. There are 3 types of von Willebrand, and the type 1 where there is reduced number is the most common that you would encounter. And in the picture, as you can see, that is basically A is what normal von Willebrand number should look like, and B is what is reduced, so type 1. And usually these patients will present with bruising, mucocutaneous bleeding, heavy menstrual bleeding, and postpartum bleeding is how you will catch them. Usually for workup, you will see mild thrombocytopenia, unexplained prolonged APTT, platelet-dependent von Willebrand activity, or the antigen less than 30% is how we confirm the disease. And then again, for management, you can use desmopressin, usually used prophylactically for these patients undergoing surgeries, and the second line would be the von Willebrand concentrate or factor 8.
Any comments from our hematologist?
Does anybody know what blood group type patients with this blood group type have low von Willebrand levels, slightly lower than 30%. It's blood group type low. So they often get misdiagnosed as type 1 von
Okay, or 300. This condition causes increased PTINR, low platelets, low fibrinogen, and elevated D-dimer, along with schistocytes and peripheral smear. Team 1.
EIC.
Yes. Exactly, yeah. It basically is because of widespread endothelial injury and circulating coagulants. Supportive management mostly just treat the underlying conditions, and you would see schistocytes in here, so mostly associated with sepsis, malignancy, pregnancy with severe complications. Okay, target for treating bleeding in coagulopathy of liver disease when using cryoprecipitate. What is it used for and what level?
Probably
15.
When you say target, are you talking about like a platelet count?
Or what are you looking at when you give somebody cryoprecipitate?
I'm not really sure, honestly.
It's basically,
Oh, I was gonna say pick another number.
oh, okay.
Anyone in the third year class? What are you treating in a patient with cryoprecipitate for the most part? Our orange team patients are full of them. What?
You're like fibrinogen, factor 2,
Fibrinogen is
Fibrinogen. So it's basically to treat their hypofibrogenemia, and basically we target, we want the levels to be more than 100.
So when I was a resident, liver patients used to have to get FFP to get procedures done, thoracentesis. And we would give them FFP like crazy, and it would never correct their coagulation, their INRs. Number one, because the FFP doesn't get you down below like what they wanted, 1.5, or they wanted you to be 1.2. But also because at the bottom of the cascade that you guys all know now, the 1 is fibrinogen to fibrin. And if you're giving FFP, that's all those factors up at the top of the cascade, and they're not affecting the bottom, which if you're low in fibrinogen because you have cirrhosis, you can't fix the cascade. So you have to give cryo in a patient who's bleeding that's a liver patient to correct their coagulation. The FFP alone is not going to do it.
And I think that's the difference between FFP and cryo, that FFP would also come in a larger volume as opposed to cryo, and most of your liver patients are already hypervolemic, so we are trying to avoid that as well. And in most of your bleeding liver patients, if they're actively bleeding, then we would like their platelets to be above 50,000 as well. And then you can consider vitamin K if you're suspecting vitamin K deficiency in such patients, or maybe even consider anti-fibrinolytic agent like a tranexamic acid or an aminocaproic acid. Okay. For 500, treatment for acquired hemophilia.
So a bleeding patient with acquired hemophilia.
Yes. Yeah. Number 12.
We weren't sure.
I'm going to ID. Sorry, no.
One of the monoclonal antibodies.
Good thought. Well, what is acquired hemophilia?
Oh, like a medication company who just stop the medication that's causing it.
Yeah. Or, so, yeah, if the patient has an inhibitor, right? An
Yeah.
autoantibody inhibitor to factor 8,
Yeah.
or a factor that normally would cause a congenital deficiency. So this person presents later in life, they don't have a history of hemophilia, but they have like intra-articular bleeds or hemarthrosis, those kinds of things. And their PTT might be prolonged, but it's an inhibitor, so it doesn't get better with mixing, okay? So how would we treat that bleeding patient? This is hard. I didn't know this, so I learned this.
Yeah, this was kind of hard. But acquired hemophilia, like Dr. Shanar mentioned, is basically when you develop the autoantibodies against those factors, the clotting factors, most commonly factor 8 in our patient population. To treat that, we usually either do the activated PCC complex concentrates or a recombinant factor 7 plus steroids, and we could do Rituxan and cyclophosphamide as well. So since this is an inhibitor, the coax studies actually would not get corrected with the mixing study, as opposed to the hemophilias that we talked about before, which is basically a deficiency. It is these antibodies that inhibit the factor concentrates from being effective. 3 different types of PCC exists, which I wasn't aware of before this as well. So it's basically 3-factor PCC, 4-factor, and an activated PCC. And the activated PCC is the one that contains 4 coagulation factors, both inactive and active. So activated PCC would be the one that we would use in acquired hemophilia.
And do we have, what do we have here at the hospital? 4-factor? For a while, we only had 3, and the difference was factor 7. So now we have factor 4. 4-factor, which includes factor 7.
Okay, it's getting clot in here for $100. The most common inherited thrombophilia in those of European ancestry. Number 10.
Factor 5 light.
Yes, perfect. I guess one strong point to make is many people call this factor 5 deficiency.
They have a factor 5 Leiden deficiency, and that is by definition incorrect. So don't say that. It's not a deficient factor 5 Leiden, it's an atypical or an abnormal factor 5 Leiden.
So in a natural or a normal human being, factor 5, basically the work is it acts as a procoagulant. And to maintain the equilibrium of hemostasis, activated protein C inhibits it. In this mutation, factor 5 becomes resistant to that inhibition from protein C. So these patients actually have a very high prothrombotic state from that. And most of the people that we see are heterozygous, and they would have 4 to 8-fold increased risk of developing their first VTE as compared to other people who do not have this mutation. And many of them would remain asymptomatic as well. But having said that, even if we diagnose someone from factor 5 laden, recent studies suggest that these patients are not at higher risk for recurrent thrombosis compared with healthy persons, which comes into play when we are planning the duration of anticoagulation when you first see these people with VTE, which might be the same as normal population. Okay, for 200. Can someone name 3 of the indications to initiate testing for thrombophilia disorders? In which patient population would we start testing them? How about team 13?
You were saying maybe like someone who has like lupus or like antiphospholipid syndrome?
Like, how would they present it though?
So like their symptoms?
Mm-hmm.
So any patient who clots, who has a clot, who do you test and who do you not test? So where, does it depend where the clot is, the age of the patient, like who are the people that you would test for thrombophilia?
Or perhaps what type of clot, venous or arterial, something like that.
Maybe if they're having like their symptoms, like they have signs of like bleeding, like PTA or like purpura.
Or any particular location of the clot.
That doesn't help.
Oh. Okay. Let's pick one of the third years. 4.
Is it arterial thrombus?
Mm-hmm.
Familial. What arterial, any arterial thrombus? Like a cold foot? Are you gonna do a hypercoagulable workup on something like that? So a hypercoagulable workup, who are you gonna do that? Is it, does age matter?
Young.
Okay.
Failed to watch it.
How about, is there a clot location that makes you think, oh my gosh, this is something weird I need to work up? What about Budd-Chiari? Or cerebral sinus thrombosis? Maybe we need to just, this doesn't, nobody gets points. 0 points, let's tell us the answers.
Okay, so I think there are like six conditions where you would check for thrombophilias. It would be thrombosis at multiple or unusual sites. And by unusual, we mean portal, hepatic, mesenteric, or cerebral veins. Or if you're having recurrent idiopathic thrombosis and we don't know what the cause is, any unprovoked thrombosis in patients younger than 45, you might consider checking them for thrombophilias, or first-degree relatives with thrombosis before age 45 as well, and anyone with warfarin-induced skin necrosis and arterial thrombosis. These would be the patients that you would check for thrombophilia. For when you decide that you are going to check for thrombophilia, it's usually these 5 conditions that you usually check for: protein C and S, antithrombin, factor V Leiden, and prothrombin gene mutation. And if someone comes in with warfarin-induced skin necrosis or you diagnose somebody with this condition, it mostly is protein C condition. For you to suspect antiphospholipid, I think arterial thrombosis and peripartum patients, pregnant patients with recurrent pregnancy losses would be the patient population that you would think of those, or anybody who has like lupus. And anybody who comes in with hepatic and PVT, those are the 2 conditions where you might consider JAK2 mutations and paroxysmal nocturnal hemoglobinuria workup as well, because polycythemia might present with that. And then, of course, all these patients, you also kind of have to check them for age-appropriate cancer screening, because that can also increase your procoagulant condition. Yes.
I have a question about the antiphospholipid syndrome, especially that Dr. Boulay is here. I wanted to know because I had a patient when I was suspecting that a patient was having antiphospholipid syndrome in the ICU. I ordered the test and then it came back positive. I think it was a beta-2 globulin that was positive. Yeah. But I was told that still you can't make the diagnosis even when you have the positive, and you have to repeat it at some time again later.
12 weeks later.
Sure, yeah, exactly. So my question now is that how do we do when you have the suspicion that this is what is causing the blood clot in the patient and you want to treat it, how do you do? Do you still have to say that, okay, we'll have to wait until we repeat it again and it's positive before we say this is antiphospholipid? Or do we just treat and then later on we repeat it again?
Do you want to?
Questions for me? So antiphospholipid syndrome is comprised of 3 different types of antibodies, right? You have your lupus anticoagulant, beta-2 glycoprotein, and then cardiolipin antibodies. Now it's risk stratified, so you have high-risk antiphospholipid syndrome and you have low-risk antiphospholipid syndrome. High-risk antiphospholipid syndrome is if you have 2 or more of those antibodies or a positive lupus anticoagulant. Patients with high-risk antiphospholipid syndrome need to be anticoagulated with warfarin. So that's the clinical implication there. If this patient just had a positive beta-2 glycoprotein 1 antibody, then any type of anticoagulant, I think Xarelto is the only one that's been studied in these folks, is fine. But yes, because these antibodies can be transient, you need to recheck the antibodies 3 months later, at least 3 months later. So if they're high risk, it's warfarin.
And the objective diagnosis of antiphospholipid is super complicated, and we will cover that as well. Okay, 300. In a patient with a history of miscarriage found to have a VTE and prolonged ABTT, what syndrome would you test for, and what are 2 out of the 3 antibodies you would order? Do one of our med students want to take a jab at that? Okay. How about team 23?
Antiphospholipid syndrome. Anticoagulants.
Can you yell? For those of us who are hearing impaired. Did you say that?
We can hear you here. We cannot hear you.
We said antiphospholipid syndrome.
Mm-hmm.
And then angiocardial lipin. Beta-2.
Mm-hmm. I guess that's the question. 2 out of 3.
Remember, it's beta-2 glycoprotein 1. I've seen a lot of people order the tumor marker for myeloma, which is beta-2 microglobulin. That is not the correct one, so you can't just say beta-2. Beta-2 glycoprotein 1.
Okay. Yes, it's basically lupus anticoagulant, anticardiolipin antibody, and anti-beta-2 glycoprotein 1. So coming to the diagnosis that was mentioned before, you basically need to have an objective documentation of either an arterial or a venous thromboembolism or a pregnancy comorbidity, which we'll come to later, and a positive lab test, which would either be the lupus anticoagulant, anticardiolipin, or anti-beta-2 glycoprotein on at least 2 occasions, 12 weeks apart, at the very least. For pregnancy morbidity, it's kind of complicated and has a nuance to it. So you have to have at least 3 unexplained pregnancy losses if it's less than 10 weeks of gestation. If it is more than 10 weeks of gestation, then it has to be unexplained death of a morphologically normal fetus, or 1 or more premature births of a normal fetus before 30 weeks of gestation because of eclampsia, preeclampsia, or placental insufficiency. So the lupus anticoagulant is the one that is kind of a functional coagulation test. So we test it either through APTT or a dilute Russell Viper venom time. But because it is functional, it is subject to change in relation to the timing of the clot and if the patient is on anticoagulants. So the other antibody tests, the anticardiolipin and the anti-beta-2 glycoprotein 1 antibody, are not affected by the anticoagulation. Tests with abnormal results should be repeated in 12 weeks, like we kind of talked about, to confirm the diagnosis. And the hypercoagulability testing is not recommended in most patients with VTE. So these are separate patient population, like we kind of talked about, that we test them in. And it is important to diagnose these patients because they would typically need longer-term anticoagulation if they develop a VTE episode. And also, it kind of factors into the choice of anticoagulant that you will choose as opposed to a general population person walking in with the VTE. Okay, going for 400 now. This syndrome with hepatic venous outflow tract obstruction, not due to cardiac, pericardial, or sinusoidal obstruction. So what is that syndrome? And the associated acquired thrombophilic condition. There are multiple conditions associated with this syndrome. You could probably just name two. How about team 16?
White syndrome
Mm-hmm.
and polycythemia vera is one of the.
Yeah. Pretty cool. Yeah.
Then we don't know the other one. We're not sure, but factor V latent can cause.
Mm-hmm. Yes. So just kind of impressing upon how many conditions blood carrier is associated with. Your myeloproliferative disorders, polycythemia, like you mentioned, essential thrombocytopenia, JAK2 mutations, paroxysmal nocturnal hemoglobinuria, and then inherited thrombophilias like factor V, thalassemia, prothrombin gene mutation, and multiple systemic diseases, sarcoid, vasculitis, Behçet's, other connective tissue diseases might also be associated with it, or pregnancy and recent contraceptive use. Okay, going for 500. These are hard. Why are cirrhotics hypercoagulable despite many having thrombocytopenia? How about 6?
Where's 6? Yeah, 6. So I think cirrhotics are hypocoagulable because their liver is not producing like the protein CNS that allow them to, or sorry, yeah, that allow them to like break down the clots.
Mm-hmm. Did you say protein CNS? Yes. So basically all the natural anticoagulants that our body should have, protein, CNS, antithrombin, and the fibrinolytic plasminogen, they all have hepatic origin. So once liver goes down, no organ is producing these factors. So you kind of lose that natural anticoagulant action in the body. Okay, you're so vain, $100. At which modified Wells score is PE considered likely? Team 19.
We're thinking 2.
2. Do you want to go a little higher?
3.
A little more? Yes. 4, basically. So these are the things that basically come into play when you calculate somebody's modified Wells score. More than 3 points when you think that no alternate diagnosis is possible in this patient and you have clinical signs of a clot in the leg. 1.5 points when patient has had previous PE, DVT, heart rate more than 100 says tachycardic, or has had recent surgery or immobilization. If patient presents with cancer or hemoptysis, you give them 1 point, and more than 4 is PE likely, and less than or equal to 4 is PE unlikely. Although D-dimer testing has a high sensitivity, a negative D-dimer cannot be used to exclude PE. So in those cases, you use the CT angiogram, which will basically give you the diagnosis. Or a high probability VQ scan can also be used for diagnosis, especially if you don't have a CT angiogram available, but VQ scan can give you false positives, especially if you have an underlying lung condition. So even after you do VQ scan in that condition, you might need a CT angio to confirm. Okay, going for 200. Length of time for anticoagulation to treat a first-time provoked VTE. Team 20.
6 months?
What's that?
6 months?
You can. Do you want to go?
What's the minimum time?
3 months.
Yes. Yeah. 3 months. So a first-time provoked VTE should definitely receive anticoagulation for 3 months and then discontinue the therapy. For people who you think that the provoking factor might persist for a little while, then you choose to go 6 to 12 months. Otherwise, 3 months is pretty safe. And in patients with first-time unprovoked VTE, so you don't have a cause, then anticoagulation indefinitely, unless you develop a contraindication to the anticoagulation due to high bleeding risk. Okay. What anticoagulant is the most effective long-term treatment to prevent recurrent thromboembolism in a patient with cancer to have found to have a VTE? So name of the agent. Team 5. It is Lovenox, but I feel now the studies say that the DOACs are not non-inferior, so they can be used as well. But yeah, for the longest time it was Lovenox for sure.
The DOACs are now okay.
So patients with cancer have 4 to 7 increased chance of having a VTE, and in the current recommendations for the initial treatment by ASH in 2021, they said you could use Eliquis or Xarelto or Lovenox. If it's a short-term period that you know of, then might as well do a DOAC for 3 to 6 months. But if it's a longer term, more than 6 months that you're anticipating the anticoagulation need, then you could do either or. Both are more effective than the warfarin vitamin K antagonists in reducing the risk of recurrent VTE in cancer patients. And also both of them do not significantly increase the bleeding risk. So I think this is a chart that Kaylin had added. It's basically cancer-associated thromboembolism without any contraindication to anticoagulation, depends on the type of cancer. So if it's an unresected intraluminal GI or GU cancer, then Lovenox is preferred. If there is any other type of cancer, then you just basically look at drug interactions between DOAC or a Lovenox. If there is, then do Lovenox. If there is no drug interaction with the DOAC, then you can do DOAC.
And the unresected GI or GU, it might be related to absorption issues, I'm guessing, with the drug.
And that's why, 'cause like ovarian cancer patients die of bowel obstructions all the time. It would seem like the oral agent might not just be
They can increase risk of bleeding or increase incidence of bleeding in patients with GI malignancies. There was an increased incidence of bleeding in patients with GI malignancies.
on dose.
Yep.
I see. Okay. In a pregnant patient found to have an acute DVT, what is the best anticoagulant to use and for what duration? Team 7. What did you say, sorry? Lovenox for 3 months. So it's basically 6 weeks postpartum, so, which is close. Because of pregnancy, patients do become hypercoagulable. And the first line of anticoagulation in pregnancy is Lovenox, and then second line would be heparin. DOACs are not preferred because they do cross the placenta, and we don't have adequate information to say whether they're safe or not. I'm not sure what warfarin's state usage would be, because I know that it's allowed in pregnancy less than 5 mg.
It's teratogenic, right?
Right.
When would you use Lovenox postpartum? Postpartum.
For a VTE during pregnancy?
Right. So if the mother chooses to blank, when would you choose warfarin?
What do mothers do to babies? When they're born?
Okay. So someone started on Lovenox for a VTE. You continue that during pregnancy, and you pause it 24 hours before delivery, basically to decrease the bleeding risk, the peripartum bleeding risk. And if you bridge only in people who have really high risk of recurrence during that delivery period. Otherwise, I think you're okay, and then the anticoagulation is started 6 to 12 hours after delivery and continue till 6 weeks postpartum.
I have a bonus question. What are the other 2 indications for warfarin? Okay.
Heart valve.
Elvis Travis.
Syndrome.
Elvis Travis. Elvis Travis.
Oh, okay. So you can use a DOAC. Cardiologists prefer warfarin. Right. But yes, antiphospholipid syndrome, right? So you have antiphospholipid syndrome, valvular AFib, and the third is breastfeeding. So those are your 3 indications to use warfarin.
And mechanical heart valve.
Right.
Okay. For which lower extremity DVTs should you consider an IR intervention? Team 27. Sorry, can you say that again?
Like for like a lower extremity DVT, that's like a complete occlusion in one of the large veins.
Yeah, that is one of the indications, basically depending on the clot burden.
Yeah.
If the clot burden is too much or a patient has like really, really severe symptoms like swelling or limb-threatening extensive proximal DVT, then yes, that's what you would consider. Usually for these patients with like severe symptomatic swelling or there's this condition with like limb-threatening ischemia associated with DVT, the phlegmasia ceruleum dolens. I think this is when you kind of consult IR, and they would prefer to do catheter-directed thrombolytic therapy, which is basically the TPA that they use. And but if the patient had, they're planning for other systemic fibrinolytic or systemic agents, thrombolytic agents, then you might have to pause that. For anticoagulation, you continue throughout. Pre-thrombolytic therapy, during, and post, you continue the anticoagulation.
So it's very few indications anymore. We used to send a lot of these patients down to IR who had just what looked like a bad DVT, and actually we've had a couple deaths because as they were going to lytic, roto-rooter out the clot, it flew up and caused a massive PE. So we don't do those as much. And I thank you so much because we ran out of time.
Okay.
But we will do more of these later. Thank you guys. We'll see you next week.